Welcome to Innovation Center's three-part video series on value-based healthcare, what every clinician should know. Payment impacts the kind of care clinicians provide. These videos will take the viewer from the current state of fee-for-service to assuming both up and downside risk in value-based care, and will tell you what you need to know to be successful. This shift from fee-for-service to value-based care means that you can take care of patients the way you were trained to do. For more on how to obtain CME or CEU credit and for important supplementary materials, please see the video description included with this video.
Hello, my name is Dr. Ken Kim. I'm an internist and a hospitalist and currently Chief Medical Officer at CMS Innovation Center, also known as CMMI. At a fundamental level, traditional healthcare reimbursement pays for individual encounters, procedures, and services. Basically, the more you do, the more you get paid, which often give rises to silos of care with little integration between patient, primary care physicians, and specialists. It's also led to uncoordinated care that could result in only managing a small piece of the overall patient rather than the whole patient. Value-based healthcare is designed to get patients and providers working together in an integrated environment where results matter and managing the whole patient and paying for improved quality outcomes leads to a better healthcare. Today, we're going to learn why we're transitioning away from fee-for-service payments and how clinicians and patients find value in payments models that pay for results, drive better care, smarter spending, and healthier population. At the conclusion of this CME activity, you should be able to identify challenges in healthcare delivery that arise from current payment system, describe what a value-based payment is and how it can impact the care you provide, recognize what CMS is doing to advance healthcare reform, and identify how you as a provider can participate in value-based healthcare.
Hi, I'm Will James. I'm a retired professor of social work and Africana studies. I've been retired for 4 years. I need to find a good barber, a good doctor, and a good dentist. If I have those three, I am on. And I found a good doctor. I found a good family practice that looked at me as a person. I never, ever talked about my future health care with past physicians. And now I'm talking about planning my future health care with my current physicians. For example, the question that she would ask me is, what are your goals? And then she would tell me what her goals were for me. At one time, believe it or not, I was 190 pounds. And the doctor says, you need to lose 20 pounds. Then I went and lost 25 pounds. That was the future health care.
Hi, I am Dr. Amy Ando, the proud mother of Sage and Zoe, who are ages 6 and 4. I have been a family medicine physician for going on 10 years now, and it brings joy to my everyday. What I've learned is that getting to know what really matters to a patient in terms of their family, their goals for their life, and even their health care helps to set the stage of then what we can do. So Will has hypertension, and so we've been really following his blood pressure pretty carefully over the years. We've been together for about 8 years, and he's been at the practice for over 30.
One of the biggest differences in the care I'm getting at Penn University Family Medicine is the portal. I'm in communications, and she's in communications with me. We've been giving her my blood pressure, writing it down and sending it to her, and she's in communications with us.
So Will had mentioned the patient portal, get my patients to send information back into the staff, the nurse care managers, who then are able to either signal to me that someone might need a medication change or to come into the office. And so we've really had this ability to see how folks are doing when they're in home, in their communities, making making their choices around food or taking their medicines and be able to bring them in when needed.
I think the team approach and the patient participation in their health care is valuable and more invaluable, I think, than just the spending more money or throwing more money at the healthcare system.
CPC Plus has enabled us to really pay attention to everything that happens outside of the walls of our office visit, and it really just makes the case of having the time that we do spend as physicians in the office. It gives us the ability to really work at the top of our license, make the medication changes, refer folks to specialists as needed, and it really helps to get all of the information that we don't have even the time for in a 15-20 minute visit. What I think is really helpful for me is to take a breath and spend the time with my patients and realize that really it's their care and it's their health that's on the line, and I am just one small piece in getting them to their goals. So I think that understanding that I am actually working with a team and that I can lean on the care manager to make a call to follow up if there's someone that I'm worried about, are they actually going to take their medicine? Or knowing that I have a mental health professional that, 2 doors down, that I can say, I'm really worried that this person is going through a depression right now. Can you give them a call? Can you come see them? So I think it's realizing the resources that we have available and knowing that we are on this wave. We are on this wave moving from a strictly fee-for-service way of care delivery to value-based, and just to keep riding it.
I'm really pleased to introduce to you a leading expert in value-based care who pioneered a team-based primary care approach, Dr. Rushika Fernandopulle, co-founder and CEO of Iora Health. Tell us your story and tell me why you changed the way you took care of your patients.
So I'm a primary care doctor, and like most other doctors, went into this because I really wanted to help people. I remember a day, it was in February, about 15 years ago. It was cold, it was dark. I had 30 patients booked that day in a typical primary care practice. And I did the best job I can with each patient. They had just put a new medical record in, and I didn't have time to do all the check boxes I needed to get my RVUs. And so I would jot notes on a piece of paper and had to stay for 2 hours after work to finish my notes. And I had a colleague who was doing the same thing. And I remember her looking over at me and saying, Rushika, every day I lose a little piece of my soul. We went into this to help people, and they come to us with such big needs. And we went through so much training, and we really can help them. But the problem is with the current system, I just can't do it. And by the way, it's getting worse and not better. And that was the moment I decided that I really needed to figure out a different way to practice. And at the core of that was we had to change the way we were paid.
So Rushika, why did you think that the fee-for-service system needed to be changed?
So the problem with fee-for-service is that it's inherently a transactional model. Everything's a transaction, document, code, bill, and then with this inane game of having to decide what level we bill at. For primary care, level 3 or 4, how many of these stupid check boxes we put in. Last I checked, transactions have never healed anyone. The thing that heals people is relationships. Relationships is why I and almost everyone else goes into primary care. So realize what we had to do if we wanted to create the right model is we actually had to get rid of the transactions so we could actually focus on the relationships. One of my favorite quotes is from the great sculptor Michelangelo, and they asked him, how do you get the Pieta, this beautiful sculpture, which is in Florence? And he said, it's really simple. I take a block of stone and I chip away everything that's not the Pieta. So similarly, what we need to do if we need to fix healthcare is chip away the cruft, including fee-for-service, that has accumulated over the last several years, so we can get back to the heart of medicine, which is really about relationships.
Taking care of patients, that's right. I've read many reports that state that by 2026, that the Medicare funds are going to run out. Should doctors be worried?
So I'm worried because I'm going to need Medicare. by after 2026. But I think we ought to be worried on behalf of our patients as well. Our job is really to be stewards of their health care. And I think if there aren't money to pay for that, despite contributing for your whole life, that's a huge problem. We as doctors are the ones that are making the orders that cost all the money in healthcare. So I think we have a real role in trying to solve the problem.
So what have you heard about value-based reform? And are there some programs that you and your team are participating today?
So I think if we want to manage the cost of healthcare, in the end, if we don't change how actual people get actual care and actually make them healthier, it's all a waste of time. It's all a shell game. And I think the only way to do that is have doctors be able to practice differently. In order to get doctors to practice differently, we have to pay people more. Again, at heart, the fee-for-service system pays you more for doing more stuff. So guess what? There are all sorts of pressures to do more stuff. That's not actually improving health.
Yeah.
So that's why we insist on value-based payments. So we want to get paid in a way that's consistent with our values and what our job is, which is actually keep people healthy and keep them out of trouble, not do more things to people. So that's why we think value-based care is necessary. So at Iora Health, we started a number of practices, and we simply insist on value-based payment because we think that's the way we can actually do our job, and in fee-for-service, we can't.
Okay. Rushika, what are you doing differently at Iora to take care of the patients?
So because we're paid in a value-based way, it allows us to completely change the care model in a way that's better for patients and better for docs. Again, in a typical model, all you get paid for are doctor sick visits, and you have a shorter and shorter time to do it. Our job is actually that we have a population of people, and they're our responsibility. What we need to do is improve their health and keep them out of trouble. So we've evolved a very different care model for it. So number one is we developed a big team. It's not just about doctors. We're really important as docs. Our job, though, is to diagnose and prescribe, tell people what to do. That's not the hard part, right? The hard part for a patient, particularly with chronic disease, is actually executing on the plan. So in my old practice, a patient would come in, I'd have 7 minutes, I'd have to say, you should eat less, exercise more, take your medicines, good luck, sucker, I'll see you in 3 months.
That's right.
And they come back in 3 months, you bad patient, you didn't do that. Well, of course, if it was that easy, we wouldn't have this conversation. So really what we do is we have a human being, a health coach. They're drawn from the community, they speak the language of the people they serve, and their job is to actually help patients execute on the plan. Hold their hand when that's the right thing to do, kick them in the behind when that's the right thing to do. And it's really stunning. We're able to interact with people, us and the health coaches, not just face-to-face in visits, but by email, by text message, by video chat. We can get patients together to teach each other. We can reach out to them proactively as well as waiting for them to come in with problems. We can take them for walks. We can go to the grocery store with them. It gives us a ton of creativity. Again, the fundamental thing is in fee-for-service, someone else, i.e. some health plan out there, is telling us what we can and can't do. Under value-based payment, it is up to us. The only question we ask is not, do we get paid for this, but will this help the patient? So one of my favorite stories is we had a patient, Mr. Edwin, who was about 55 years old. He had diabetes and hypertension and hadn't taken care of it, so ended up on dialysis. So 3 times a week he had to go to a dialysis center, plug himself in. Poor Mr. Edwin also had a bad anxiety disorder. So what would happen, not infrequently, is he'd wig out. I need to get out, I need to move. He was competent, so they had to unplug him. And he goes home. Guess what happens? He shows up at the ER the next day because he didn't get dialyzed in renal failure. They admit him to the hospital, 2 days of inpatient dialysis. On the way home, they give him a Ativan tablet. He hates it, throws it out on the way home. And the cycle continued. So 13 admissions the 6 months prior. $200,000 of healthcare costs.
Yeah.
So met with us. We have health coaches who are in our practice to help patients execute on the plan. And the health coach asked him, that must be awful, Mr. Edwin. Yes, it is. Do you ever feel that way other places? Oh, sometimes at home, I feel like I have to get up and move. Is there anything you do at home to make you feel better?
Yeah.
At home, I listen to my music, it calms me down. I said, what does he like? He likes merengue. Block an hour out tomorrow, download some merengue CDs on there. He comes in the next week, we stop everything. We go into his room, Mr. Edwin, congratulations, you win the Patient of the Month award. We, of course, don't have such an award, but we need an excuse to give him this thing. Every time you go to dialysis, you listen to this and think of us. He does, awesome. Next 6 months, 0 ER visits or hospitalizations.
Oh my.
We just saved $200,000 of healthcare costs. Why does no one do it in fee-for-service? Because they think their job is do what you're paid for.
And it's a fairly common story that the fee-for-service system could never accomplish.
Absolutely. So what happens is we can end up getting much better outcomes. And this is where you set up, I think, a really great cycle. So the typical primary care, we're in a vicious cycle that's going downwards.
That's right.
Right? We're not paid enough or the right way. We end up having poor outcomes. People go to the hospital and the ER when they don't need to. Healthcare costs go up. And what do the payers do? They ratchet down our payments. So now instead of 10 minutes, we have 9 minutes, and this thing gets worse. And we all feel in primary care in the current system, we're in this downward spiral. It's getting worse. What we do is we're investing the right way in primary care. We improve their outcomes to stay out of the hospital. Because of value-based payment, we now get paid more when people do better. We can invest that back into primary care.
That's right.
And so we're going in an upward spiral.
All right. So Rushika, tell us how technology had helped you at Iora, and more broadly, how it helps value-based care.
So in value-based care, our job that we need to do is that we have a population of people and they are our responsibility, and we need to be able to improve their health and keep them out of trouble. So to do that, of course, we need data and technology. Now, what's interesting is we need different technology than the current system. So as you know, the vast majority of doctors use electronic health records. These electronic health records, not surprisingly, are built to help the current business model, which is help them document, code, and bill higher. They are fancy cash registers. They were not built to actually improve health or keep people out of trouble. So we and many other people who have been serious about value-based care made a decision we had to build our own sort of platform. It is not a transactional platform, it's a relational platform. And what it does is it allows us to track our patients, to engage them, get data from them from wherever we are, put signals in when we need to intervene, and be able to track how our teams are doing. We call it CHIRP because it's really about communication, not about recording things. The nice thing is we don't have to do the inane things fee-for-service makes us do, like write 4-page notes for a simple visit in order to get a higher billing code. So we can actually just say what it is we did and not all the other stuff just for billing. It allows us, I think, to really take better care of patients. As you know, one of the biggest contributors to physician burnout has been electronic health records. And people blame the electronic health record. It's not their fault. It's that they are actually trying to implement the fee-for-service payment model, and that is the core problem.
So, Rushika, you're one of the black belts in value-based care in this country. So as we close our interview, any final words or recommendations for young physicians out there or clinicians that are thinking about going into or maybe dipping their toe into value-based care away from fee-for-service?
So to me, having done this for 15 years, there is no question that our future for primary care has to be in value-based care. I think the ability for us to do the job we want to do, which is actually take care of patients, to be able to have us make the decisions what gets paid for and what we do, and not some bureaucrat in some office, that has to be using some version of value-based care. We're doing it, it works tremendously. The other piece is that under current fee-for-service, primary care gets about 5% of the healthcare dollar. 5%, by the way, is probably a little less in some places. That means that 95% of what gets paid for is what I call failure primary care. I think us in primary care fighting in this little 5% box is not a tenable game. So when you go to value-based care, and particularly the far end of the spectrum, which is full risk, where we take responsibility for the whole healthcare dollar, all of a sudden it is now up to us how much we want to put into primary care. So our proposition is that we should put 10 or 12% of dollars into primary care. That doubles down on it. Right? That gives us the resources to spend enough time with patients, to have teams that are robust to help them to deal with mental health conditions and social determinants, and all the things that allow us to do our job. Right? I think without that, this is not a winnable game.
All right. It's great insight. Thank you for coming. Thanks for the interview and your insight.
You're very welcome.
Thank you. All right. please join us for the next session on aligning financial incentives for better care with Dr. Bob Kocher, who is an expert in this field.